Hello, good afternoon. We are getting ready to share my screen. Perfect. All right. I wanted to welcome everyone to today's presentation of Hormones in Your Health, Understanding Hormone Replacement Therapy and Surgical Menopause, brought to you by the Abdominal Cancers Alliance. I'm Amy Hanley, and I'm the program director for the Alliance. We'll be walking you through a few housekeeping items today before we begin. This webinar will be a short presentation. We received several questions from registrants, and I have worked to answer those questions throughout the presentation. If you have additional questions, please add them to the Q&A box and send to all participants. We will work to try to get these answered as time allows. All lines are muted for noise reduction, and the presentation is being recorded and will be available on the Alliance's website through our YouTube channel and will also be shared via social media. Finally, if you have any questions about this or any other Alliance event, please contact me at the email listed on the slide. And really quick before we begin, I just wanted to share a little bit about the Abdominal Cancers Alliance. It is an independent nonprofit connecting and empowering the abdominal cancer community to see that every patient receives appropriate and timely care throughout their cancer journey. We work to connect the larger abdominal cancer community to patients and resources to ensure we save and improve lives. We do this three ways: by raising awareness with the public and care providers, making connections to resources and care, and guiding patients and caregiver navigation throughout the cancer journey. The Alliance has an established central information system of resources on abdominal cancers and treatment options, such as CRS and HIPEC, which can be found on the website listed at the bottom of this slide. And as we get ready to start this presentation, I wanted to introduce you to today's speakers. First, we have Tammy O'Rourke. Tammy spent the first 20 years of her nurse practitioner career in primary care. However, in 2019, she moved into regenerative medicine. In early 2021, she completed her first hormone certification course. Tammy continues to update her hormone knowledge, and she is currently pursuing a certification with the North American Menopause Society. She speaks nationally and internationally on the topic of healthy aging. Next, we have Dr. Teresa Diaz-Montes, a highly respected and board-certified gynecologic oncologist, serving as the Associate Director of the Laya Segal Ovarian Cancer Institute and the Medical Director of the Neil B. Rosenshine Institute for Gynecologic Cancer at Annapolis and within the Mercy Health System. She practices gynecologic oncology center at Mercy Medical Center in Baltimore and is renowned for her expertise in diagnosing, treating cancers of the female reproductive system. Dr. Diaz-Montes is also recognized for her work in minimally invasive and robotic surgery, her dedication to patient-centered care, and her leadership in clinical research aimed at advancing gynecologic cancer treatments. And with that, I am going to turn it over to Tammy to go ahead and start our presentation.
Hey, can you see my screen,
Yes,
Amy?
yes, we can.
You can see the first slide then?
Yes.
Perfect. Perfect. I always want to make sure that that's in order. Um, so, as Amy mentioned, my name is Tammy O'Rourke. I'm a nurse practitioner with my PhD. Actually, a little bit different system in Canada than in the US in terms of DNP. And today I'm going to be talking to you about understanding hormone replacement therapy and surgical menopause, both from a professional standpoint, because I've seen thousands of men and women for HRT prescribing, and a personal standpoint, because just 5 months ago, not even 4.5 months ago, I guess, July, August, September, October, November, 4.5 months ago, I was in Mercy Hospital receiving the HIPEC for stage 4 or stage 3C ovarian cancer. And I'm very blessed to be on this part of my journey with my ovarian cancer. So let's get right into the subject here. And I'm hoping that my colleague Dr. Diaz-Montes will provide some perspective as we move along with the slides when she feels it's relevant. Let's talk about why hormones matter to begin with. Hormones are chemical messengers that control multiple physical and mental functions. I always find this very fascinating that estrogen alone contributes to over 400 functions in the female body. 400 functions in the female body. That's quite a feat for this female dominant hormone. In my studies and in my sake of interest in learning about menopause, I understand that only three mammalian species survive past menopause. Humans, short fin pilot whales, and orcas. Every other mammal, once they stop being able to reproduce, meaning they're going into menopause, they die. The other hormone that really matters is testosterone. And it's important for both men and women. Brain, bone marrow, sex organs, and skin are very important for that hormone. So, hormones play a vital role in our physical, psychosocial, and our mental health. But aside from those symptoms that we experience with menopause, it also plays a very important role in chronic disease development or the cessation of that. So, keeping things at bay like osteoporosis, dementia, heart disease, high cholesterol, and hypertension. And I'll bring up some of the newer studies that suggest this to be true and even more important than we used to know it to be. So let's identify sex hormones and thyroid for now. So the five major hormones are testosterone, estrogen, progesterone, DHEA, very long name, and I'll explain that later, and desiccated thyroid, both free T4 and T3. T3. We know that there's a differentiation between synthetic and bioidentical. And synthetic hormones are sort of conventional hormones. They're more complex, and they're made from materials such as horse urine. I'll talk about this a bit more. Bioidentical hormones are made to resemble your body's own hormones. Some are plant-based and some are animal-based. For example, desiccated thyroid comes from pork. So here's conventional HRT. It's otherwise known as conjugated equine estrogen. And yes, the equine stands for horse, and medroxyprogesterone acetate. And you can see here the chemical structure of these hormones. And why does that matter? Well, it matters because it's very different from our own progesterone. So women produce progesterone, men don't. If you look at this chemical composition, you can see over here, and I just get my little highlighter here, uh, my little laser pointer. You can see over here that it has this additional piece to it. And so what does that mean? Well, it doesn't sit on our receptors the same way that this progesterone sits on our receptors. So I only prescribe this type of progesterone, not this type of progesterone. Another example, we have here human progesterone, bioidentical progesterone. It's a little bit of an extra, but you can see here that this has a lot of an extra. And here's human estrogen, and here's bioidentical estrogen. So patients always ask that question, well, what's the difference between BHRT and just how we know hormones? Because, they wonder about Premarin versus bias. They wonder about estradiol versus Premarin. So that's basically what I was trying to describe to you, is that there's a variance between bioidentical hormone replacement therapy and traditional or conventional hormone replacement therapy. It doesn't mean that all bioidentical hormone replacement therapy is compounded. It means that the synthetic versions of hormones, such as the conjugated equine or the progesterones or the progestins, look very different from a chemical composition point, and that's why they don't fit into our receptors the same way that the bioidentical ones. But some bioidentical ones are created from pharma, like estradiol and estrace, for example, oral estradiol and transdermal estradiol. Surgical menopause, of course, is the abrupt cessation of hormone production, estrogen, testosterone, and progesterone. As women age, they go into natural state of menopause. And when the ovaries stop producing estrogen, they stop producing estrogen, never to produce estrogen again. And I always say she packs her bags, she leaves the building, and she takes progesterone and testosterone with her, never to come back. Surgical menopause is a result of surgery that removes the ovaries and other components of female reproductive system. Can be due to both a benign condition or a cancerous condition. Interestingly enough, in the evidence that I read in preparation for the surgical menopause presentation, the guidelines say that all women should receive counseling about HRT prior to surgery and the role of HRT prior to leaving the hospital. However, according to one large study, Jang et al. In 2020, it was reported that only 50% of women in premature surgical menopause use HRT. Now, you'll find that this will become very important as we move into the evidence about chronic disease cessation and prevention. Here's one example from the International Menopause Society that I picked up on this article. It's just written October 6, 2025, is that women with surgical menopause may exit the workforce earlier, but hormone therapy could help. So for those 50% of women who are in early menopause due to a surgical intervention, they are seen as leaving the workplace earlier due to symptoms and potential side effects of that surgical menopause procedure. And according to the British Gynecological Cancer Society and the British Medical Society in 2024, all women should be able to access advice regarding transition. So I think this is where we need to get to, and we will get to eventually with more education and more guidance in this area. So what does it mean when you don't have enough hormones? Well, you feel sick, you feel weak, you feel old and unhappy. Remember? I said estrogen produces or is responsible for over 400 functions in the female body. One of the top ones, and one of the symptoms that many of my female patients come to me with in menopause is memory. Tammy, I don't have the memory I used to. I've got this brain fog that just pervades me from retrieving words when I need them. So, especially for high functioning professional women, this can become a big barrier to them in their careers, and probably one of the reasons why they leave their career early. It also leads to hot flashes, night sweats, vaginal dryness, anxiety, mood swings, irritability, anxiety, insomnia, depression, palpitations, varicose veins, urinary leakage, dizzy spells, panic attacks, itchy skin, feeling like your skin is crawling, memory lapses, weight gain, ooh, itchy ears, all sorts of symptoms. And I'm still learning because I have this health assessment that I use at the beginning of my visits that goes through all of the systems, but I have women constantly telling me about other symptoms that I didn't really put on my list. So we're still learning about everything that early menopause or menopause contributes to. So I thought I'd start with some myth busting. And I've labeled this slide what we used to think and what we know now, because that's the truth of the situation, is that many, many moons ago, the HERS and the WHI studies were prophesized as tripling the risk of breast cancer, doubling the risk of breast cancer, linked to breast cancer, and these old dogs are still wagging the tail. This is the evidence that is presented in offices, although you can see the date here, 2002. So there's a whole generation of prescribers who are still encultured or culturally believe that hormones aren't safe for one reason or another. And the evidence suggests that the amount of time spent in medical programs on menopause is very limited. despite the fact that every woman will experience menopause and some symptoms thereof of that transition. But we know better. It wasn't scientifically valid, and they prophesized the numbers the way that they saw them at the time. And it was reported a 26 increase in the risk of breast cancer in the first publication. The number went to in fact, it was 8 additional women per 10,000 that developed breast cancer. There was an increase in breast density, which was also associated with breast cancer. But in a 20-year follow-up, estrogen alone demonstrated a significant lower risk of breast cancer and breast mortality. And estrogen and progesterone demonstrated a significant risk of breast cancer, but no difference in breast cancer mortality or death from breast cancer. And they stopped the study early due to this increase of breast cancer and heart attacks when the rates were not statistically significant. The other flaw to this study was that they focused on women over the age of 60 with pre-existing chronic conditions, but they generalized the results to all women. And I still recall this because I was fairly new nurse practitioner during this time, and we were basically ripping Premarin out of the purses of menopausal women. I found this slide when I was Googling because I love the internet and I love AI too, right? I have this AI bot chat. He's my assistant. And there's a small farm, I shouldn't say small, 50,000 mares in Brantford, Ontario, that produce all the pregnant estrogen urine for Premarin, Prempro and Aprella, and they chronically get these horses pregnant. They take their foals and then they get them pregnant again. So some are labeling this as horse slavery. Why did we ever think this would work without issues? I'm not sure, but it was the preferred science at the time. In fact, now we know that hormones help. Some hormones can protect clients from developing cancer and many other chronic diseases. There's a long list. Regardless of what I do to a patient or what I prescribe, 1 in 8 women will develop breast cancer due to age, genetics, environment. I could talk for 2 hours on microplastics and the effects of our environment on both male and female hormones, but we don't have time to get into that. We also know now that having a family member with breast cancer is not a contraindication to therapy. And we know that providing hormone therapy as early as the age of 25 for patients with PCOS can protect them against female organ cancers because these women are estrogen dominant, progesterone deficient. These hormones can be useful in treating some cancers, like after the fact. Patients are eligible to have them. They can relieve symptoms and improve quality of life. And I'll show you a chart later on in the slideshow that demonstrates studies and where different cancers can be still prescribed hormone therapy: ovarian, melanoma, mesothelioma, and even prostate. This is one example that I took from, it says 2 days ago, but it was actually earlier this year, where hormone therapy reduced insulin resistance in healthy postmenopausal women. So insulin resistance is where the body starts to not recognize or not accept insulin on the cells to use blood sugar as energy, and we start storing blood sugar as fat. So controlling that's very important, and I find this very useful. HRT is very useful in my patients who are perimenopause and menopause who can't lose weight, because that's one of the things, their weight just keeps going up and up. So what we know now, we know that HRT is good for cardiovascular health, brain health, bone health, mental health, genital urinary syndrome of menopause, weight gain, metabolic syndrome, and hypoactive sexual desire disorder. For example, and I'm going to go back to the WHI study, and one of the reasons it was canceled, or one of the reasons it stopped, was because it said women are having heart attacks. There's this estrogen plus progesterone for secondary prevention of coronary heart disease in postmenopausal women. The HERS study that was associated with the WHI said, and it said during an average follow-up of 4.1 years, did not reduce the overall rate of CHD events in postmenopausal women with established coronary artery disease. Remember what I said? They were treating 60-year-olds over with chronic, pre-existing chronic conditions. But it did increase stroke events, these thromboembolic events where a clot develops and gets sent, potentially can get sent somewhere else. What we know now is that heart disease is the leading killer of women. We've actually surpassed men. There's increasing rates of hospitalization for heart disease in women, and 1 in 3 women will die of heart disease. One, HRT has the potential to improve women's cardiovascular risk profile through vascular function, lipid levels, and glucose metabolism. Women under 60 within 10 years of menopause, the benefits of HRT outweigh the risk. And for women over 60 and more than 10 years, it's always important to do a benefit risk analysis. And you can see the new study here from 2022 is that menopause, hormone replacement therapy, and reduction of all cause mortality and cardiovascular disease. It's about time and timing. And that's what these take home messages are about. Let's talk about brain health. The risk of dementia is higher in women than men. 2/3 of Alzheimer patients are women. That's the reality of the situation. We're the ones in nursing homes who don't recognize our own children as we age. We know that hormone replacement therapy is associated with improved cognition and larger brain volumes, 2023. And we also know from a systematic review and meta-analysis of the effect of menopause hormone therapy on the risk of Alzheimer's disease and dementia from 2023 that this work is important. Its effects are promising. The verdict is still out, but we're learning more and more every day. Remember, estrogen equals memory. It's responsible for that function. Bone health. Osteoporosis affects 1 in 3 women. For men, it's 1 in 5. 30 to 50% of us, women on the call, will suffer a clinical fracture in their lifetime. 70% of hip fractures occur in women. What's the difference? Our estrogen dominance. That's our dominant hormone. Take home message is that standard HRT is effective in preventing bone loss associated with menopause and decreases the incidence of all osteoporosis related fractures, including vertebral and hip fractures, even in women not selected for a high fracture risk. And estrogen is the only prescription that supports bone growth. All osteoporosis meds decrease additional bone loss. However, there are some new injectables that are laying down bone as well. But if you look at the side effect profile of those medications, it's kind of scary, right? So hormone replacement therapy, 2014, even as long ago as 12 years ago, we knew this was the case. So this comes from the British Medical Journal, and it's sort of a timeline of what happened in terms of the history of hormone replacement therapy. And estrogen only HT first came into practice in the 1960s. We went through many iterations, but in 1993, we had the Women's Health Initiative and observational studies began, right? And then we stopped prescribing hormones. And in 2002, it stopped early. And then now, this is the British Medical Journal. This is a pretty high profile journal. Few women who would benefit receive it. That's the continuing issue, is that we know women can benefit, but very few receive it. Now, what about hormones after a cancer diagnosis? Is it safe? This is one of the questions that I had because I've been on hormones for 10 years now. I had longstanding endometriosis. I had polycystic ovarian syndrome. I had 5 fibroids. I was on a wait list in Canada for 2.5 years to see gynecologist. Still didn't get a call for a hysterectomy. Had I received my hysterectomy in a decent amount of time, my ovarian cancer wouldn't have initiated itself. Not to say that, the fibroids or the PCOS contributed to that, but certainly we know that the endometriosis could have contributed to that. But I didn't get that call. I was waiting in Canada, and that's an issue. And I know many of you are Americans on the call, and you tout Canada as a great healthcare system. I went to Mercy to get my surgery because it's not accessible to me in Canada for the same cancer. We do it for bowel cancer for women, but we don't do it for ovarian cancer because we say we're waiting for more evidence. So I found this in the The same British Gynecological Cancer Society put out this guideline, and they look at it from a quality of life and longevity perspective. And it is still safe for some, but not all. So you can see these levels. Look at this right here, this vaginal estrogen column. It's safe for almost all cancers. And I'm going to tell you what benefits that produces. And most recently in the US, the FDA just removed the black box warning. Even more pertinent is that you can get vaginal estrogen over the counter in the UK. And I'll show you which two types you can get there. So you can see that even yellow, right, predominates, yellow and green. There are very few red sections on this in terms of hormones after a cancer diagnosis with a gynecological cancer on this chart. I was surprised by this because this is new evidence for me that I hadn't looked at before. So interesting that all cervical cancer patients can receive systemic or vaginal estrogen. Vulva or vaginal cancers can receive vaginal and systemic estrogen. Low and intermediate risk germ cell, even some types of ovarian cancer can receive systemic and vaginal estrogen. It's deemed safe by two major organizations in the UK. So, what about vaginal estrogen? Because there's a lot of talk about vaginal estrogen. Do it, do it, do it, do it. As you can see, the green. Here's what this does for us: it improves vaginal dryness, reduces painful sex, treats burning, itching, and irritation. It improves urinary symptoms. It can decrease. It's the most effective non-antibiotic strategy for preventing UTIs in postmenopausal women. It restores vaginal pH in the microbiome, strengthens vaginal tissue, improves blood flow and tissue healing. It's ultra low systemic absorption, which means it stays right in the area it's supposed to. And even when I have women on systemic estrogen, they may still need vaginal estrogen. It's sort of a unique, I'm not going to say organ, but it's a unique tissue that I always say, our vagina needs its own source of estrogen. And look at all the benefit just from this local systemic estrogen that a woman can receive. Imagine how much benefit that she will receive from getting a systemic estrogen. Can be used long term, and it supports quality of life. Comfort, confidence, sleep, intimacy, emotional well being. It's one of the underrated tools in menopausal care. Here's what I was talking about in the UK. Available without a prescription. So you have to have a consult with a pharmacist, like you do here for some things in Canada or the US. We have prescribing pharmacists here. But you can get Gina, which is vaginal tablets of estradiol, or you can get Ovise, which is an estriol vaginal cream, and you can walk right in and get it from the pharmacist at a pharmacy in the UK. So I took a look because I had been seeing some things online about vaginal estrogen and cost savings. It's in the billions. So the best data that we have is around recurrent UTIs in postmenopausal women. And urinary tract infections cost the US about 2.4 to 2.6 billion per year. Vaginal estrogen can cut that UTI frequency in half. So here's the cost savings. It can be between 1.2 and 4.8 billion dollars per year. So you can imagine if every woman in a nursing home who's having frequent UTIs was now prescribed vaginal estrogen, what would the quality of life and cost indicators amount to in that population? It's quite impactful and quite disheartening that it's not being done. So estrogen's our main hormone. So I did focus on that for the majority of the presentation because that's where a lot of questions come around. I do prescribe progesterone and testosterone, and I believe there's a couple men on the call. So I didn't want to go without mentioning testosterone in men. There are many benefits of testosterone in men: improved sexual function, increased energy, reduced fatigue, improved mood and well-being, increased lean muscle mass, decreased fat mass, improves bone density. It may improve metabolic health. In fact, there's one study out of the State University of New York, who had my first graduate degree there at Buffalo. And this study says that they found in their scientific research just a couple of years ago that testosterone may reverse type 2 diabetes in men Interesting, right? And we're also seeing it earlier that, that insulin resistance with women. So we have a huge cohort of aging clients or aging people in our society that have diabetes. Imagine if all of those patients were to receive HRT and we could do a study, either be an RCT or observational or post retrospective study on the incidence of diabetes over the next 10 years. I think you'd find it quite outstanding. And for some men, it can improve anemia. Of course, not without an assessment into why that anemia was in the first place. I can tell you honestly, and I had this conversation earlier with a physician colleague. He was interested in testosterone. We had a little conversation about it for both men and women because it was just on the front of the New Yorker just recently last month. They had an article about testosterone in their publication. And you can see there's some risk. I rarely see these in my practice, but most men that I put on testosterone come back to me not to say, "Hey, Tammy, take me off it." They come back to me and say, "Hey, Tammy, it's time for my refill." So I get a sense from my male patients that is very important for their quality of life. DHEA, remember I said I'd come back to this? So DHEA, probably a hormone you haven't heard about. Interestingly enough, you can buy it at a vitamin store over the counter in the US. In Canada, it's a controlled substance. It's a hormone produced by the adrenal glands, the same glands that produce cortisol as our stress response. It's a precursor, so it's sort of like a stem cell for sex hormones. Our body will turn DHEA into testosterone and estrogen if it can, and it drops by 80 to 90% from peak levels by the time a man reaches 70. I prescribe it to both men and women, and it really improves and keeps their golf game up. That's what they tell me. For men, same for women, it improves mood, decreased depression, supports energy, well-being, increased libido. It's a very strong anti-inflammatory. And two of the things that my patients express, both female and male, when they're on the DHEA, is that, "Oh, my joint pain's gone. I can move my body differently than I used to before." I didn't, but a colleague put my husband on some DHEA last year, and he's like, "Where's this been all my life?" Because he's been real sort of tough on his body, and back pain, shoulder pain. The DHEA took most of that away. Risk, of course, are the same. Acne, oily skin. Sometimes it can cause some irritability. One thing that's not on the list here that I do find some of my female patients complain about with the DHEA is a bit of hair loss. So if they do get that from, increased testosterone and then that DHT, that's sort of a different type of testosterone that evolves from them having higher levels of testosterone. If they do complain of hair loss, I'll either decrease the dosing or I'll take them off it to reduce that. I did have some questions that I took from Amy, and I've incorporated them into the presentation because I wanted your voice to be heard. So I'll just run through those quickly, and then we'll take any other questions. I believe Bo was watching those. It's so hard for me to be on the end of this end of the presentation when everything's quiet. I can't see how people are responding. If you're nodding or if you're getting something from this or if you're finding it engaging. And I'm not looking at the chats right now, so I'm interested to see. Okay, great, that's good. Amy's giving me the thumbs up because it's like I'm sitting here in my office just with the monitor in front of me. So let's talk about adenomyosis and endometriosis. Again, had stage 4 endometriosis. Very difficult to diagnose for gynecologist. I was once admitted to the hospital. They thought it was my appendix. It was actually my endometriosis. And they put me on Lupron. So they put me into instant menopause in my early 30s. Worst experience of my life. Talk about a hard crash. HRT does not cure either of these. The goal is to decrease the bleeding in both cases. It typically revolves around estrogen dominance and not enough progesterone to oppose that estrogen. So I do put patients with these two conditions on progesterone and a supplement, DIM, which can decrease estrogen production. So it's sort of like a nutshell of that question. And then there was a question about exercise timelines. If the person who registered that about wanting to know about exercise timelines, I'm thinking that's after surgery. Maybe Dr. Diaz Montes can comment on that if we get some clarification on that question. Cycling progesterone. Yes, very important. There's a couple ways to cycle progesterone, both in menstruating and menopausal women. There's the classic cycling, which mimics our natural cycle. And it's where you're on progesterone from days 14 to 28. So that's when your cycle's known, it's predictable. Sometimes if you're estrogen dominant, or if you have PMS, PMDD, or you're in perimenopause, we can use this type of cycling. And why do we cycle days 14 to 28? It's because, woo, day 14, you ovulate, you release an ovum. If you ovulate, that ovum comes down through the fallopian tubes into the uterus. If it's not implanted, it disintegrates. That raises women's progesterone after ovulation. Perimenopause, we don't always ovulate. And PCOS, we don't always ovulate. And in estrogen dominant women, we don't have enough progesterone to oppose that estrogen. So that's your classic cycle. 10-day protocol. PCOS women, or women who don't ovulate or have very long cycles or perimenopause, we just cycle it in for 10 days. We don't know when to cycle it in because they're might not be potentially having a period. My perimenopausal protocol is 200 to 300 milligrams every day at bedtime. Same with menopause. Women love progesterone. It bathes the uterus, it bathes the brain. And I always use this statement from one of my clients. She said, Tammy, if my house is on fire, I'm putting my progesterone in my purse. She goes, don't get me wrong. I'm going to wake up my husband and take my pets too. But progesterone comes first. It's going in the purse. It's coming with me because I can't sleep without it. And it calms your mood. It's like, when you get anxiety, palpitations, and that irritability where you're just raw. And if your husband's breathing beside you or your partner's breathing beside you, it irritates you. It calms all that down so that you don't go from 0 to 50 in 1 second. You actually get your patients back. So it's very influential in women's health. Progesterone risk. Microdosed progesterone, it doesn't increase risk of breast cancer, blood clot risk, or stroke risk. That's why I use it. I don't use progestins, which are synthetic. And it's why it's widely preferred in modern HRT protocols. Ovarian cancer screening, great question. If you've had a partial hysterectomy, there's no screening mechanism for ovarian cancer. Of course, we can do a CA-125 to see what the levels are if a physician suspects or a nurse practitioner suspects ovarian cancer. Mine was over 2,900 when I was first diagnosed. It's supposed to be under 35 to be negative, and I'm proud and very happy to present that the last time I had it measured, it was 29. So that's success. However, there is a doctor, Dr. Christopher Miller at a McGill University in Toronto. Actually, I think McGill's in Hamilton. He's working on using an M-Detect blood test, the same one that we use for endometrial cancer, and it stands for methylated DNA marker detection. So stay tuned. We may have a screening test for ovarian cancer coming from Canada in the next few years, still in testing. ADHD, I have this too. This is a fantastic question. A lot of my female patients come to me saying, I think I have ADHD. I did the self-questionnaire or I've been diagnosed. Well, hormone changes affect ADHD in perimenopausal and menopausal women. I did not know this up till almost a year and a half ago. I thought estrogen was all about brain fog. Then I read a study that said estrogen decline worsens ADHD. Perimenopause makes ADHD highly unpredictable, gives you more anxiety, irritability, and sleep disturbances. So menopause or perimenopause can unmask that ADHD that's been sitting there for all these years. I explain it to my female patients as this. When we were younger, little boys were being diagnosed with ADHD. They were hyperactive. They couldn't focus in school. But we, as women, developed strategies to get us through most of our reproductive years and be very successful. I mean, I just started taking 5-Ns 2 years ago, and I wanted to understand it. That's why I dug a little bit deeper. But I was never diagnosed as a youth. Probably could have helped me be a neuroscientist, even though I did get through, 12 years of higher education without it, because nobody diagnosed me because I was a woman. We think ADHD results are typically male. So it can unmask this previously undiagnosed ADHD. Labs. Big topic of discussion. Most of my patients come to me and say, "Oh, my doctor said I can't, I'm not going to do labs. There's no labs that I can do for you." I use labs for a variety of reasons. One, I want to make sure there isn't another issue causing the symptoms. So I do a very extensive serum analysis. I use labs to educate women because some women think that, oh, if I take HRT for a year, my hormone's going to come back. No, estrogen left the building. Took progesterone and testosterone with her. If there's one thing you remember from this talk, they're left. They're not coming back, never to be seen again. And I also use them to inform treatment choices and treatment effect because in some women, they'll have an appropriate testosterone level or DHEA with an undiagnosed PCOS. And in other women, they'll have very low levels of DHEA or testosterone. So it does impact the way that I treat patients and the hormones I choose for them. And I also use it as a follow up. So I do labs again at 10 weeks after initiation of therapy. All women are different absorption, metabolism, and excretion. I could put all of you, all women in the group, on the same dose of estrogen. I can guarantee you that all of your levels are going to be different when I check you at 10 weeks because you're all different. You're all uniquely different. And I use it to augment the lived experience. 85% of my diagnosis of perimenopause, PCOS, menopause, endometriosis, adenomyosis comes from my discussion with the client. I can identify from their story and their experience what the diagnosis is. Their labs just confirm for me what I'm hearing from them. HRT lifespan, simple as this, until you're 125 years old. I have a female patient who's 72. She vacations from Canada to Palm Springs 6 months of the year. She had a gallbladder taken out 2 years ago. Her biggest concern since that gallbladder was taken out is that she can no longer fit into her size 6 golf shorts. That's her big concern. I said, I can't do anything about that. That was the gallbladder they took out. It has nothing to do with your hormones. She's on no other medications, no diabetes medications, no high blood pressure medications, no lipid medications. So for me, the proof is in the pudding, and there's safety into older age, and it's necessary for chronic disease development. Another question. What about testosterone? Is that risky for women? Risky for men? No. The research shows that physiological dosing, so dosing that is equitable to the dosing that you would have had at a younger age, does not surpass your ovulation dosing, of course, because as we know, testosterone rises with ovulation. It's meant for reproductive purposes in mammals to get you interested in sex during that time so that you reproduce. Doesn't cause breast cancer, heart disease, blood clot, or stroke. It's classified as safe when prescribed properly. And there are actually 4 countries in the world, only 4, that have a uh, pharmaceutical brand of testosterone dosing for women. South Korea, the UK, Australia, and New Zealand. I believe the US is going to be next from the talk that I hear. So you'll have some there, but Canada's about 20 years behind, so we should get it in 2046. And that is all that I have. And I did that in 45 minutes, Amy.
Good job. Good job. I have a couple of questions, but if anyone
Sure.
else would like to drop a question into the Q&A, we can try to get to those. Um, Question I have, do the benefits of HRT outweigh risks with mother's history of death due to leiosarcoma? I might have
Mm,
mispronounced that.
Leiosarcoma. That I'm not sure. Maybe Dr. Diaz Montes could speak more about that because I haven't had that experience in terms of patient care.
Um, the thing with leiomyosarcomas, they are, just to clarify and explain to the audience what a leiomyosarcoma is. A leiomyosarcoma is a tumor that arises from smooth muscle. Smooth muscle is in any part of the body. It makes your intestine. It can make your blood vessels. And the most common association with sarcomas is usually of the uterus. because the uterus is made of moose muscle, and within the uterus, sometimes you can form a fibroid, and that fibroid can turn into a sarcoma. I don't know in general for other types of sarcomas because they can arise from any body part, but from gynecologic, I don't think it play a role. They are extremely rare. We're talking about 0.05% of a chance of a fibroid turning into a sarcoma. So there's not a lot of data that you will never find like big studies done in terms of clinical trials or evaluation of what to do or not to do with a sarcoma or a leiomyosarcoma or a sarcoma in general, because they're extremely rare. Just going back a little bit to the topic of discussion, one thing that we know that estrogen in general is a stimulatory effect. And when Tammy was talking about fibroids and adenomyosis, estrogen can stimulate fibroids, can stimulate adenomyosis, can stimulate endometriosis. So if I have a patient who is postmenopausal and they are taking hormones and they have fibroids, they need to be aware of the possibility of that fibroids getting larger, or the possibility of that adenomyosis acting up, or that endometriosis also causing some symptoms. I don't think there's any correlation of using hormone replacement therapy, like it will be disadvantaged to like cause them to turn into cancer if you're postmenopausal. So I would assume from the information that we have that the answer will be no, that I think you should be fine.
Thank you.
All right. I have another one. If you were already beyond menopause and then had your ovaries removed during cytoreductive surgery, should one expect further changes in hormone levels?
My initial response is no, because again, the ovaries have stopped. Like in menopause, the ovaries have stopped, and estrogen, testosterone, and progesterone have left the building. Now, in my case, I was on estrogen, testosterone, and progesterone prior to surgery, and I'm no longer on those just at this point. But as you saw in my slides, it's still maybe a possibility, because my cancer is all gone now. But I didn't experience. I was surprised. I didn't experience any sort of symptoms like I thought I would have, because I've been menopausal for 2 years and I was suddenly taking off my hormones, but I think my body was so busy dealing with everything else. So the quick answer is no. Would you concur,
Yeah, I concur. When you are menopausal and it's been a long period that you have been menopausal, then you usually don't experience any symptoms. I have a few patients that I have done like removal of the ovaries for other reasons, not necessarily cancer related, that sometimes they complain that they can have some hot flashes after the surgery. But normally the way you were feeling before the surgery should be the same. One thing that I want to add up that I see a lot of people come to the office complaining of hot flashes and all these kind of symptoms that we assume could be menopausal. But there's a lot of things that can cause you to have a hot flash, and not necessarily means that you're menopause or you're entering menopause again after you went through menopause, because you can have hot flashes from medications that you're getting. You can have hot flashes because you're stressed out. Because a hot flash, what it is, it's just a reaction of your body. It's like your blood vessels reacting to a stress level and then emitting that energy that make you feel hot. You know, you can have thyroid disease, you can have a cardiovascular disease, you can have a lot of things that we always try to blame it into that, oh, I'm menopausal, I'm having hot flashes. By the end, I need to get hormones, but not necessarily so. Like if you are menopausal and you're past like 10 years, 20 years, and you start having to have some kind of symptoms like that, we cannot just conclude, oh, I need hormones, because maybe you have maybe another serious thing going on, and we just need to evaluate. So that's why Tammy was talking about maybe, they do like a more comprehensive evaluation, blood test, let's look at this as an overall picture before we jump into this wagon, and let's just do hormones and mask something that could be a real problem.
Yeah, that thorough assessment and that serum, that initial serum investigation, so important.
Okay. I have a few more quick questions to get through. Can we use pharmacogenomic testing to anticipate BHRT dosing?
I'm not sure. I don't know that very much about pharmacogenetic testing. Dr. Diaz-Montes?
Me either. I don't know what specifically this is. What is the context of the question? I don't know.
Okay. We might have to get back to you on that question. For those sensitive to hormonal changes or have PMDD, is there a difference in how HRT is prescribed?
Yes, it may be prescribed earlier because they've developed that condition PMDD, so they may need hormones earlier than perimenopause. I see patients in their 20s with this condition. So it can be prescribed earlier, and they may need different variations of a hormone protocol. Another reason why personalized precision prescribing is so important for females, in that not every female is the same. Actually, no one female is the same as the next.
Okay. This person said they went into surgical menopause after CRS HIPEC when they were 45. They are now 51, and it sounds like HRT might still be a benefit for them. Is that correct?
Depends on the type of cancer, and I'll have Dr. Diaz-Monte weigh in on this.
Yeah, I agree. It depends on the type of cancer that the person has. Like, there's definitely some cancers that they cannot be given hormones because then you can feed the cancer and the cancer increase the risk of a recurrence. And she's putting a slide in. Not like we assume that a cancer, because there's a rise in a body part, like all the cancers are the same. Like, there's different kinds of uterine cancers, there's different types of ovarian cancers, they have different presentations, they have different behaviors, some of them are more aggressive than others. Same thing happens with breast cancer. So depending on the type of the cancer, then we decided if you are or not a candidate for hormone replacement therapy, because the least thing they want to do is feed something. The ideal time to treat somebody is usually within that window of 10 years or less when they go through menopause. Like, if I have somebody that I do surgery and there's no contraindication to do hormone replacement therapy, and I put that patient in surgical menopause, that will be the ideal time, because that's when you will have the benefits. If it's past like more than 10 years, usually there's no benefit in terms of long-term benefit in terms of health. How I address to my patients is there's sometimes you can have symptoms that can be very bothering to you, and it can impact your quality of life. And then we can have a conversation, because if you are having a big impact on your quality of life, maybe you will not get the cardiovascular benefit, maybe you will not get the memory or the cognitive benefit or the bone benefit. But for example, if you cannot sleep, if you these hot flashes that let you sleep and you cannot sleep, you cannot perform on the next day, that's a quality of life issue. And then that we have to have a conversation. Okay, if I do this intervention, I can help you get better. That's going to improve this, not necessarily these other benefits that maybe they will not at some point of your life will have a difference, but in terms of quality of life it makes a difference, then sure. But usually we talk about the first few years that you go through menopause, that you're going through menopause, that will be the bigger of the benefit of using hormone replacement therapy.
So the poster, the question came from updated to say they had low-grade mucinous appendix cancer. So, and they're 6 years out from surgical menopause. Is there still a benefit?
There could be a benefit because the mucinous appendiceal cancers, they are not associated with, like, they're not hormonally related tumors, so there should be a benefit for that patient. But again, I think that person should have a consultation and a discussion of what will be, what are the symptoms that you're experiencing? It needs like a more comprehensive discussion to see what are the options for that individual.
Okay. I don't currently have any more questions that we're able to answer. Um, so with that, I want to thank everybody for attending. I want to thank our two speakers for joining us. We did record this session and we will be sharing it out on our social media probably on Friday, a week from today. But also it'll be on the Alliance's YouTube channel and it will be posted to our website, which is abdominalcancers.org. If there are any other questions, you feel free to email me directly at ahanley, Hanley, at abdominalcancers.org. And I just want to thank everybody for spending your Friday afternoon with us.
Thank
Thank you
you.
so much.
Thanks so much.
Thank you. Have a good day.
Okay, bye bye.